Hello, everyone, and welcome to this hangout. We're really delighted today at Evidence-Based Mental Health to have you join us and to be watching this if you're watching it through our YouTube channel. Today we'll be discussing a really important paper by one of our digital assistants, Roxanne Keynejad. This is the WHO Mental Health Gap Action Program, mhGAP. Intervention Guide, a systematic review of evidence from low and middle income countries. We're joined by Roxanne, who's the lead author on this paper. She's an advanced trainee in psychiatry and is at King's College London in the UK, and is beginning a PhD in global mental health. We're delighted to have her. We're also joined by Tarun Dua, who's at the WHO, where she is at the Department of Mental Health and Substance Abuse there, and serves a number of different roles, but is really an international leader in implementation of programming for mental health and neurological disorders. We're also joined by our editor-in-chief, Andrea Cipriani, who's joining us from Oxford, and I'm Michael Ostacher. I'm an associate professor at Stanford University, and I'm joining this call from Palo Alto, California. Roxanne, why don't you begin and give us a little bit of background on the paper and what we'll be discussing today. Oh, I also wanted to remind people that if they want to make comments about this live, they can do it through a hashtag EBMHchat. And also in our Twitter feed at EB Mental Health, you'll be able to find a link to this paper, both the full text paper and a copy of the PDF. So you'll be able to link to that through this. So Roxanne, why don't you go ahead?
Well, hi everyone. Thank you for organising the Hangout. It's a pleasure to join you from Cape Town. I'll just hold up here the conference guide. I'm currently at this meeting in Cape Town, which is called the Global Evidence Summit, conference of its kind, bringing together a real international focus on evidence-based practice across healthcare, and really trying to bring together clinicians and researchers on the one hand, and policymakers and governments on the other hand. And it's really trying to acknowledge that there is a gap between the two. Because evidence-based mental health as a journal focuses exactly on that area, the interface between clinical practice and evidence. This paper is something that we wrote trying to address that area, particularly in relevance to mental health, especially in low and middle income countries. Just a little summary about the paper. It looks at a particular piece of evidence called the World Health Organization Mental Health Gap Action Program, or mhGAP. mhGAP is something that I'll ask Tarun to tell you a little bit more about. But with mhGAP came the mhGAP Intervention Guide, mhGAP IG. And the mhGAP IG is focusing on simplified clinical algorithms for evidence-based diagnosis and treatment of priority mental health conditions. Priority conditions include the commonest mental disorders, such as psychosis, affective disorders, particularly depression and bipolar disorder, substance misuse disorders, and importantly, it also includes epilepsy because commonly in low and middle income countries, epilepsy is considered a mental disorder, whereas in high income countries, it's usually a physiological condition. There's a manual that is very much evidence-based. In it comes could have Tarun as the world lead on MH. But just to give you a bit of a summary about the paper, this is an evidence-based tool for mental health around the world, but there wasn't any evidence synthesis that had been conducted to show whether this manual had been and whether it had been did. This paper is available for the next 2 weeks, open access. So it'd be great if as many people who are interested to read it, who won't otherwise be able to access the manuscript, download it in the next 2 weeks. I don't know, Michael, if you'd like Tarun to say a bit more about mhGAP before I go on to talk about the findings.
I think you can, I think you're doing great. I think you can lead this. Tarun, if you would like to join in, that would be terrific.
So can you hear me,
Yes,
Michael?
Yes.
Lovely.
Yes.
Okay, so I'm trying to sort out the optics here as well. Thanks, and thanks for this opportunity to reach out to a large number of audience. Taking a step back and on how and why we started with this mental health gap action program, and I would like to emphasize the term gap here, was the reason because of the high gap between the burden and the resources that are being spent on mental health in countries. So if you look at, for example, DALYs, it's 10%. If you look at the resources, it's 1% or 2%, depending on the country that you're coming in. And if you look at the third gap, looking in terms of the treatment gap, if you look at the treatment gap, it has been reported in many countries, even 90% treatment gap. And I think from a public health perspective, from a human right perspective, from a moral perspective, this is unacceptable that we should have such a high treatment gap. And I think what we wanted to, by this program, by the Mental Health Gap Action Program, come up with a set of simple tools, and where the focus was on non-specialist healthcare providers, because we know the number of specialists in countries is limited. We won't have this ever the mental health services, and that was the reason that we focused this on non-specialist settings. And one of the important tool was development of our mhGAP intervention guide, which we call as mhGAP IG. And this is the guide that is based on evidence-based recommendations for the priority mental health, neurological and substance use conditions that Roxanne talked about. And these are, this is something that is, we have, and these evidence-based recommendations are included available on our mhGAP Evidence Resource Center. So that was the rationale for launching the mhGAP Action Program and developing the intervention guide. And this is something, this is also fits in very well with, if you look at the new environment, why this is relevant is because of the Sustainable Development Goals, which includes a target of promotion of mental health well-being, and the Comprehensive Mental Health Action Program that has been adopted by all member states to work on a coordinated service delivery response at country level. So, so Michael, I'll stop here and maybe come back to this point about the future directions and see some of the questions that might arise from this discussion.
Well, actually, I think at this point it would be helpful if you described a little bit more about what the goals of the implementation program are on the ground. In other words, for many people in the West, they have a clear view of what the healthcare system looks like, and it's obviously very different in developing countries. And so, when you're trying to do this, what specifically are you? You know, you can even give an example of a specific country that you were. Where you initiated this. What does it look like on the ground? Healthcare and how it's provided, and what are the kind of barriers or things you would need to overcome in order to even begin to provide mental health care to those populations?
Thanks
Yeah,
for giving this
thank
opportunity. I think starting as we started with Mental Health Gap Action Program, and as we rolled it out, our main objective was scaling up care for mental health, neurological and substance use conditions, scaling up mental health services at a country level. So that was our primary objective, that how the services can be scaled up. And the focus that we wanted to have in this as part of this program was to working with the non-specialist healthcare systems. And the way that we worked with different countries was, one is, you know, thinking in terms of as we go with the approach, thinking in terms of a coordinated approach where we are looking at having a systems level thinking on looking at the program. So what I'm trying to say here is starting from the beginning to say what are the barriers to implementation, what are the needs, what are the resources available, and how we can be efficient in use of the current resources. So this is not about always identifying new resources, but working with the current resources. The second point I would like to emphasize is the adaptation and contextualization of the program to the local settings. That is extremely important. There is no one size fit all. And I think we need to, rolling out the program, think in terms of what really will fit in the system settings. And for example, the prescription guidance. In some countries, nurses are allowed to prescribe. In other countries, nurses are not allowed to prescribe. And how do we take that into account? The third was when we think about training. One, when we are thinking about the training of healthcare providers, not to think beyond training of a mechanism of supervision, mechanism of both clinical and administrative supervision, and also training of program managers and policymakers. I think that sometimes it never happens that, you know, they're not trained in mental health care services. Thinking about services delivery issues, an important issue is how do we improve access to medications? For example, giving the example of epilepsy, one of the major reasons for barrier or major barrier to the treatment availability is because of non-availability of medications. So, and the last point I think I would like to make is that trying to it's not always possible or feasible, but to see how programs can get some monitoring and evaluation be included in their approaches. So those were some of the principles that we followed, and in some cases it worked well, in some cases didn't work, and I think some of this is reflected in the article that Roxanne will talk about.
Yeah. Roxanne, go ahead. Oh, we can't hear you. Unfortunately.
Yeah. Can you hear me?
Yes, we can.
Yeah. Thank you very much, Tarun. And I suppose just to add, in terms of a country example, something that I have personal experience of is Somaliland, which is a self-declared autonomous region in the north of Somalia. It's an extremely low-income setting from point of view. And King's College London has a partnership with Somaliland called King Somaliland Partnership, which we're really excited was just nominated for a Health Service Journal Award for International Partnership. And I've been to Somaliland once face-to-face, but have been involved in educational work with the country for the past 8 years. And an example of how mhGAP has been really valuable is that it's a simplified manual that we can take to the country and use with medical students to show them a basic idea of what a simplified clinical assessment and treatment plan for priority mental disorders can be. And not just medical students, because doctors are very thin on the ground, but moving forward, we want to use mhGAP to also train non-medical study nurses, but also less qualified than nurses, just frontline health workers who are spending day-to-day contact with people with mental disorders. To give you a context, in Somaliland, there are very few qualified psychiatrists at all. And as a result, the people who have day-to-day frontline diagnostic contact with people with mental disorders will not be psychiatrists, will not be psychiatric nurses, but will be quite limited in their training. And that's why something like mhGAP is really important.
I mean, and now that you've sort of laid the background around what the public health issues are, the human rights issues and moral issues are, which I think are quite astounding. I think it's important. I think it would be a good time for you to go through your paper, talk about what you did in your review, and then after you've done that, we can get back to talking about sort of the details of what it's like to implement these things and to try to improve care at the level of individuals.
Thank you. So I was interested in this study, and together with Tarun, Professor Graham Thornicroft, and Prof. Corrado Barbui, who are also extremely eminent leaders in this field, to look into the research literature, both the academic publications and also the grey literature, to find out what we actually know about documented implementation of the mhGAP intervention guide. We know from policy and non-academic sources that mhGAP has been widely used in 90 countries around the world. So we know that it has had reach, and that is largely through the effective network of the World Health Organization. But what we don't know is how much data has been collected about its use. And we don't know how it's been used and in what ways, in what places. So that was the ethos of this review. And it was a very simple systematic review methodology using search terms, and it was relatively straightforward to conduct because the terminology of the mhGAP intervention guide are fortunately terms that don't capture irrelevant results in your search. So that made it a very feasible search to perform. And what we found was 33 published options of how the mhGAP intervention guide had been used. So 15 of the 33 described training courses, which is to be expected because the purpose of the mhGAP intervention guide is both to be used clinically, but before it's used clinically, you would expect clinicians to be taught it. So 15, almost half, were training courses. 9 of the papers that I found described, without particularly focusing on training, they described clinical implementations of the mhGAP intervention guide. So this is clinical settings in which healthcare staff were using the guide to diagnose and treat mental disorders. The other studies were quite miscellaneous in their focus, but there were 3 that were simply describing how they had adapted the mhGAP intervention guide to the country that they were in. So one in particular was an extremely detailed country contextualization in Nigeria. Specific modules were chosen that were most rated and they were adapted, and there was a very valuable qualitative description about how that was done. Another was a particular focus on the dementia module done in Nepal, for example. Two more studies used mhGAP as a control. I thought that was really interesting. They were randomized controlled trials of other interventions, and rather than having a control arm of no intervention, they used the mhGAP as a kind of enhanced treatment as usual, which was, I think, really interesting, and we could talk about more if we have time. And the last paper was using mhGAP to develop a rating scale of psychological therapies. So if you think about those 5 different examples of ways mhGAP was used, they were quite diverse, quite heterogeneous, and they encompassed quite a range of countries. Most of them were in Africa and several countries in Asia, such as India and Nepal. But what they do show is that large areas of the world that use mhGAP are not publishing what they find either in the grey literature or in academic journals. Although we have found probably more than we expected to find, there's room, much more room for qualitative and quantitative evaluations of how mhGAP is used to be published.
Yeah. And so what do you make of your findings, and what do they suggest for how things need to move forward?
Well, I discussed them particularly with Professor Thornicroft, whose specialty is the area of stigma in mental health research especially. And his take on it was that actually 33 is quite a robust literature. Clearly, it's not the whole literature that we would hope to find, because we know that mhGAP has been used in 90 countries around the world. But actually 33 is not bad, and it's probably testament to the increasing evidence of initiatives like Cochrane and other partners that are taking part in the Global Evidence Summit this week in Cape Town. Even in settings that are very low in healthcare resources, are endeavouring to engage in evidence-based practice, are endeavouring to collect data and write it up. And the World Health Organization has been very galvanizing in that respect, bringing together reports. And my personal take from having read all of the papers is that even though some of the journals and publications that are included might be considered by the authors to be relatively low impact, the richness of qualitative data that they provide is extremely valuable for any practitioner or any budding academic in a low resource setting. And so actually it's a good news story, and it's hopeful, but if anybody's watching this who is doing an mhGAP implementation, no matter how small, even if it's online, even if it's remote, whatever ways they have of writing it up, even in a blog or a more original way of sharing evidence, I would just really encourage them to do so, because the more of the literature that's available, the better.
That's true. Tarun, you're joining us from Geneva at the WHO. So tell me what this data sort of says to you about the direction that the program is going in, and what this means for the near future, at least.
We came out with the intervention guide in 2010, and as Roxanne emphasized, based on the information that we received from countries, it has been one, it has been translated in more than 20 languages. Two, it has been implemented in more than 90 countries now. So that's an example of a good uptake. As I mentioned, this is not, but all of this is not reported in peer-reviewed or published, or even sometimes even in gray literature. Then, we have been also in the 6 years that it has been being implemented, we received feedback from the field, and we have actually came out with the revised version, the updated version, which we call as version 2.0, which was released last year. So we have the algorithm, we have the new mhGAP IG available, and people can download it freely. It's open access, available on our website. Now, there are issues around making it available. If we look at some of the things that are available, is to make taking forward by different categories of healthcare workers, by countries. And so what we are doing now is actually creating the mhGAP app. So the app, we will be launching it in our annual forum, the mhGAP forum, on 9th, 10th October. So this is something not like the Apple phone, but but something I am sure people working in the mental health field might like it. And I was actually looking at some of the wireframes before this call, and then looking at the app, how it's. I feel this will be important in. And this is something that will be available offline. So it's something that can be more easily available to non-specialist healthcare providers, and something that will enhance the uptake of much more at country level. So that's one of the things that we are doing in Geneva. The other thing that we are also doing in Geneva is to, come out with an updated, with our updated intervention guide, came out with updated set of training package that, again, and we are, the hard copy will be available shortly in the PDF versions, but we'll be working on an interactive e-learning materials in the next few months, and something will be made available in 2018, along with guidance on how to implement. So what we are calling it as an operations manual, the ops manual, that policymakers or people who are working at a district level, or NGOs or academic researchers, can find it helpful in taking forward mhGAP. So this is something that we are working in Geneva, and I think it's important, because as you look at the countries, all the countries have signed in for universal health coverage, and universal health coverage includes mental health coverage. And I think mhGAP is a good approach to achieve that particular goal and target.
I was speaking many years ago to one of the founders of Android, who's recently sold his company to Google, and he was specific about the idea that iPhones were going to be for high-income countries, and Android was going to be a scalable, inexpensive resource that could be used across the low-income world. So I think it's terrific that you're rolling out apps in this. Andrea, you're one of the international experts involved in the development of mhGAP rather. Did you have a comment or a question that you wanted to ask?
Yeah, there are a few questions I'd like to ask Roxanne and Tarun. The first one, it's a very interesting publication, and I was very happy when Roxanne and I started discussing this project. And one of the things that struck me was, if I remember correctly, about 50% of papers in your systematic review are about training. And I think it's a very important finding, because probably it's where you can really change materially practice because you are implementing the tool. I was wondering whether Roxanne can give us more details about some of the studies or the challenges about training mental health gap in lower and middle income countries.
Yeah, I think it is a really important finding. As Tarun alluded to right at the beginning, there is a mental health workforce gap as well as a mental health service gap. So as much as people like me, psychiatrists practicing in London, might hope that a proportion of trainee doctors in low-income settings would want to become psychiatrists, the reality is that few of them will, and it's much more important that general medical practitioners, not just doctors, but general medics, have some basic skills in mental health assessment and treatment rather than becoming specialists, which is not a sustainable model in the low-income setting. So training of a multidisciplinary set of clinicians is extremely important. And I think Tarun and colleagues in D as familiar as anybody with the reality that in the low-income setting, people can be really bombarded with training. And there can be an issue of a kind of flavor of the month or whatever is getting funding this month, they're asked to go on a training course. HIV for a long time was very prioritized. And what we certainly would like to see is that mental health is not something that is currently an interest of funders, actually becomes mainstreamed across healthcare. As Tarun said, universal health coverage has to include mental health, and it's not an optional extra. So yeah, use of mhGAP for training is really important. What the paper shows is that most of the implementations that were reported in learners in all of the modules of mhGAP. So mhGAP has slightly more specialized modules such as behavioral disorders of childhood, medically unexplained symptoms, epilepsy, as I mentioned, and generally almost all of the reports that we found in the literature had to make practical decisions about which modules to train in and which not, which I think is an important finding because it shows that even though something positive has happened where there's been money, time and effort available to focus on mental health, still the gamut of mental disorders has largely not been able to be trained in. And that's a kind of pragmatic, realistic finding that is important for us to know.
But I mean, how did they deliver training, but also how did they evaluate the methods of training? Can you give us some examples just to figure out?
Yeah, that's really important. Most of the training described was face-to-face courses between a kind of expert individual who would be the lead trainer and then groups of healthcare staff who would attend the training. And actually, evaluation of the training was extremely variable. So that's something also for us to learn from, that when version 1 of mhGAP IG was rolled out, it came with quite a simplistic assessment of a kind of multiple choice, best of 3 answer test about just basically determining the knowledge level of the learner. And what we did find was that a lot of studies had rolled out that knowledge assessment from WHO as their evaluation and simply said, after the course, learners scored higher in this knowledge test, therefore the course showed a good effect. Whereas some other courses were a little bit more clinically orientated and were able to look at whether after the course clinical staff identified more cases of, for example, depression than they had beforehand. but certainly it was heterogeneous how courses were evaluated.
I have a question about the difference between cultures when it comes to thinking about approaching mental illness. You know, so I have the I have the app open. I have the guide open 2.0, and I'm looking at it, and it's really it's really quite brilliant with the general principles of care and how people should be assessed. But I was thinking that in different cultures, Tarun, it's I think someone may be typing, and it's if you can put on mute while you type, it would be more helpful. But I was thinking in terms of depression, some cultures, all cultures have a different view of what it means to be depressed. Some don't see it as a mental illness at all. Some don't recognize it, but some don't see it as a mental illness. In other words, they see it as a flaw of character, or as representing something about the person's core identity. I mean, so how do you sort of bridge that? I noticed that for psychosocial and non-pharmacologic treatment and advice, the first thing you do is psychoeducation, and I wonder whether or not that's a bigger piece in some places than in others. That is, even educating providers, who I assume are well educated in their own countries, about mental illness, because they may have a focus more on medical illness, physical illness, than they do on mental illness, and it may be bound to the cultures in which they live. Do you have either of you, Tarun or Roxanne, have a specific comment about that?
Yeah, I'll answer that, and then if Tarun wants to add, yeah, that criticism is well known in global mental health, and is really important to listen to understand, but has also been robustly rebutted as well by people such as Prof. Thornicroft, who unfortunately couldn't join us today. Yeah, there are high-profile thinkers who have argued that mental health is at the extreme. They've said it's culture-bound entity entirely, and global mental health as an entity is a modern day example of, even at a kind of quite provocative level, people have argued that it's and like a colonialization by sharing our high-income countries' ideas of illness with a completely different culture. But there have been quite compelling critiques of that view, particularly based around pervasive prevalence estimates of disorders such as depression, psychosis, epilepsy, and others around the world. I'd be really interested to hear what Tarun's view is, but you have reminded me that in this paper we found 2 studies which interestingly used mhGAP, this relatively Western model, with traditional health practitioners in Kenya. So really interestingly bringing together quite a biomedical model of mental disorder with completely spiritual and cultural approach, and showed really interestingly that the mhGAP model was very effectively used by traditional health practitioners to detect depression in Kenya. And that's a really interesting finding that hasn't been shown before, that these 2 approaches to mental distress brought together. Tarun, I don't know if you want to add to that.
Thanks, Michael, and I think this is an important issue that comes in, and mhGAP is based on the biomedical model, but acknowledges that has to be implemented in collaboration and in synergies with the other models that exist within the countries, and adapted and contextualized to the cultural, economic, social context as much as possible. So I think that's extremely important as we move forward. And there have been some examples where this model works very very well. And this is something that comes to my mind in relation to the involvement of, for example, traditional healers and the role they play in society. And this is something that we worked in Ghana with the Ministry of Health on implementing, specifically in relation to severe disorders and focusing on epilepsy. And so and these involve dialogues with the traditional healers. And I think what worked out was and what with the approach, what happened was actually we had the traditional healers referring patients with epilepsy to the healthcare facilities for treatment. So that was an example where the two models we thought were able to coexist and within the current health system that exists in the country. And this was possible that as the program was rolled out, even at the planning stage, in the stakeholder consultation, it involved working with the traditional healers representatives or the faith healers representatives, and in some cases, even religious healers or the religious leaders. So for example, in one of the stakeholder meeting we had in Mozambique, we had, a person representing church, a person representing Islam, and then a person representing even Hindu religion from the country joining the discussion, and to see how we can work and use and work in synergistically. So I think this is extremely important that we work with all different stakeholders as the program is rolled out at country level.
So it seems to me that each country or different countries would have completely different needs in terms of the level at which you need to engage them around implementation. In other words, some that rely more on traditional healers, where there's a mistrust of, even as Roxanne was talking about, sort of Western conceptualizations of illness, might be different from a place which does not have that as the major problem, where the major problem instead is access to care. And they might implement these sort of things if they had the resources to do so, and that this mhGAP IG gives them a framework for trying to implement that. And so, and one of the things that I'm thinking about, since a lot of the focus of the journal is around picking treatments, medication treatments, what are sort of the issues that are involved with sort of getting medications to places that don't have a lot of financial resources? I mean, so how do you use the local or governmental infrastructure to allow people to get treatments that they otherwise wouldn't having access to?
So that's maybe if you look at the treatments, there is the whole issue of access to medications, and then we have the whole issue of access to psychological interventions. So starting with the access to medications, as we know, that's a big issue in many of the countries. And what I would do is maybe see how we have worked in some of the countries to enhance access. So giving some examples on how this approach we have taken within as part of mhGAP implementation. So there are, if you look at all the different access issues, they range from selection to availability to affordability and appropriate use of medications. And very often what we find at a country level, that the national essential medicine list may contain the psychotropic medications, but they're not available at the primary healthcare level, in the facilities where they should be distributed. And some of the things that that when we discussed with the countries come in, that there could be issues with procurement, there could be issues with the supply chain, there could be issues with the prescription legislation or the appropriate training of the healthcare providers or even the pharmacists to distribute the medications. So different challenges, they come up, and there is very often not single challenge but multiple challenges. So one of, for example, like the issue, giving an example from another country, in Myanmar, what happened was when we started the discussion was that the medications, there was the issue of not being available at the primary healthcare level, and what we found out, the mechanism to do is that each of at a district level, the townships, they can put in some budget for mental health medications if they know about it. So this was the whole issue came down of raising awareness of program managers, and very often when we talk to them, that they don't do it because they didn't think that the mental health disorders can be treated at primary healthcare level. So sensitization and awareness raising, and it could be a simple. So making those district managers, program managers, empowered to see that the medications can be made available, the treatments can be done by district level, and this will improve the issue. Sometimes, yeah. Go ahead, Mike.
No, go ahead. No, I don't want to interrupt you. Go ahead.
So that was, for example, one barrier and one solution to look at. Sometimes the other barrier is that, okay, there is for example, especially for psychotropic medications, there is a cap, and the cap that exists in the country is actually based on the reason that is because they have a very few number of people with mental health disorders being treated, and there's very less amount of medications required, and therefore the INCB thinks, the International Narcotics Control Board, the recommendations, the standards are that you don't require you only require X quantity and not 10X quantity because you are only treating 20% of people. When you implement a program like mhGAP, there is increased demand, and then you realize that so there is a problem with the quantification of the medication, and so this requires a little bit working with the policymakers, with the Ministry of Health, and changing in the policy, improving the cap, so then they can import more drugs than that is required. So now I think what I'm trying to also emphasize a point here is that this approach focusing on the essential medicine list, and we are not going on to the range of other medications. And I think just using the concept that the countries are using within each of their ministries, and mental health drugs are part of those essential medicine list. So these are some of the strategies that can be used at ground when we are looking at the mhGAP implementation or any mental health program implementation in countries.
I will editorialize a little bit and reference Andrea's terrific work doing meta-analyses of our data, and suggest that the essential medications are probably the ones that we really only need, and that going beyond, we have a few that work, and the rest, I'm not sure how much added value we're getting. But I think what you bring up is really, really, really important and fantastic, which is that you're in a position to problem solve barriers to implementation on all these different levels, and the notion that it came down to who was making a purchasing decision at a local level based on what medications they thought they would need, and had an impact on whether or not the medication was available at all, is a remarkable is a remarkable outcome of the work that you're doing, which is to say that somebody has to buy the medications and stock them for them to be available. And if you just make people aware, oh, we have a program that can help you understand how to identify and treat patients who have mental disorders, even if you don't have specialized training in it. But in order to do that, you have to have the medications available. These are the medications I think you ought to ask for. I think that's a wonderful and terrific outcome of this, and a really nice example of this in action. Andrea, you may have had another question that you wanted to bring up.
I agree. It's very fascinating to have this global view. I've worked with the WHO a few years ago when I was in Italy, and it's fantastic to move from our reality as clinicians with patients to something at a national level or global level. And going back to the comment by Tarun, one of the other things I really liked in Roxanne's systematic review was the section about the local adaptation. And in your initial presentation, you mentioned Nigeria. And I found this study very interesting because we tried to have different steps. So probably it would be nice to have some more details about what they tried to do in order to implement from the individual level to the national level this hugely important tool as mhGAP.
Anybody care to comment? Oh, you're speaking. Go ahead, Roxanne. I couldn't hear you.
I wasn't sure if Tarun was going to answer.
Roxanne, why don't you go ahead and I will chip in. So please go ahead.
Yeah, I think it's really important that context has to be taken into account, and there's a big danger when an extremely powerful entity like the World Health Organization releases comprehensive guidance like that resource-pressured departments may misunderstand how it should be used and simply issue it en masse and expect it to be relevant to all contexts around the world, which is clearly not going to be likely. So yeah, I agree. The paper from Nigeria is a really nice example of taking a lot of time and care to try and focus in on what aspects of mhGAP as a model are relevant to a particular community, not an entire country even, because clearly within a country like Nigeria, there are a number of tribes, many religions, many languages. So the authors focused quite carefully on a particular region and selected specific mhGAP modules and adapted the manual completely, translated it, adapted what the training contained, and evaluated it. And that was a really, really nice example, but probably not an example that there will always be resources to provide all over the world. Another thing I wanted to highlight about this review was that there are a lot of papers a number of papers that were protocols, and I think in the literature that's also a really positive development, that even when the research is going to take years to come to fruition, when the results are going to take time to be known, that what is planned at the outset is still getting published as a protocol is hugely valuable in terms of having a lot of rich contextual information for individuals in low-income settings who want to know what's been done before. It also means that when the results are finally known, if they're quite different from what has been expected, that's also really nice. There are two papers in this review by an author called Chesmal Sridharana, who very sadly died recently, but had done really important work in Sri Lanka. And he has written really candidly in both his papers about the difference between what was planned and then all of the barriers that he faced when he finally came to try and implement his work. And actually, although he didn't manage to achieve what he hoped, all of the things that he might have thought were failings were actually hugely valuable to learn from, to know if you were then in your own setting wanting to conduct an mhGAP intervention, they'd be mistakes that you wouldn't make again because he has taken the time to document them?
So to add from my side, I think I'm so glad that paper from Nigeria gets published, because I think this is some of the places on when we look at the adaptation that there is so much of rich information that one can gather. And from the number of countries that I have worked on the adaptation process, I feel it's really crucial. And very often it doesn't require many resources. What you require is actually a group of stakeholders to come together. And this serves many roles. So not only in many objectives, it's not only that you are doing only go through the adaptation process, but they learn more about the approach. They get the ownership of the project. There is a collaboration that is established, and I think this is extremely important part of the process. So I think this is very, and I don't know, many of the journals don't really like to publish these processes kind of papers, but I think for people working especially in an area like mental health, this has important learnings.
Sure, I think that's completely true, that we often are looking for great syntheses of data that can be comparable to each other, but the qualitative approach that was done in this paper by you, Roxanne, and others is just extremely important to explain what the work needs to be at the level of individuals across the world. And I think it's quite remarkable. Andrea, you have a question you wanted to bring up?
I have a couple of minutes, yes. I have one question for Roxanne and one for Tarun. For Roxanne, is another striking thing is that mhGAP was used as a control condition, control intervention, and somehow it's good to know that it's considered standard care. Probably it's not really standard care, so if you could comment on this. And for Tarun is what next? You mentioned implementation and the update of the guidelines, the 2018 edition. So I think the challenges are ahead, and it's definitely very good news to have talented young psychiatrists as Roxanne leading this project and a real global and worldwide collaboration.
Yeah, it's wonderful. We have one question from Twitter that I thought we'd asked right before we finish. Is mhGAP being implemented in any of the low and middle income countries in Europe, where, to my knowledge, MH services are very scarce? So, I mean, that's just a specific question about implementation in Europe itself.
I might leave that one for Tarun to answer, but with respect to how mhGAP was used as a control intervention, yeah, I thought that was really exciting as well, because the rise of randomized controlled trials in low-income settings is a really positive one and shows a move towards more robust evidence from low-income settings. As I mentioned, the Global Evidence Summit that this Hangout was planned to coincide with is really trying to promote robust evidence from low-income settings. So seeing that Mental Health Gap Action Programme could be the control in a range of diverse different studies is both lovely to think that that could be a baseline that all patients expect, but also a really imaginative way of gathering more evidence about its use. And even though the purpose of the RCT is not to evaluate mhGAP, collecting data on it can only be a good thing. And I think looking long term raises the prospect of gathering big data about its use. So that's really exciting. Do you want to answer the question about relevance to Europe?
Yeah, Tarun?
Yeah, I think two questions. Yes, there are a few countries where it is being implemented. Two countries that come to my mind are Turkmenistan and Ukraine. and come, and I can give more information. And in terms of the question about what next, I think one is, yes, we are definitely that this requires partnerships and collaborations across various agencies, organizations, groups of people, and academic community has a big role to play. I think it's important that we think in terms of academic researchers, also as in many of these low and middle income countries, as the public mental health leaders. And I think this is something that if we can enhance the thinking, that would be extremely important. And the second would be enhancing the collaborations between the program policymakers, program managers, academicians, and civil society in making this work. So my main message is partnerships and collaborations and building up the public mental health leadership. And glad to see that Roxanne is doing her PhD in global mental health. So we need more psychiatrists to move into that thinking. So
totally agree.
And from our side, we would be really very keen to work with countries on implementing and supporting and being part of that team. And last point is an urge, an ask to all the academicians and researchers to publish on mhGAP and share their feedback with us so that we can improve it and make it much better for country implementation.
And on that note, that's a terrific way to end this hangout. I want to thank everyone for joining us. The wonderful Tarun Dua from WHO joining us from Geneva, and our rising star in psychiatry, Roxanne Keynejad, who's joining us from Cape Town, where she's wonderfully agreed to present her paper, and to Andrea Cipriani in Oxford, the editor-in-chief of Evidence-Based Mental Health. I'd also like to thank Verona behind the scenes, who's done a wonderful job putting this together and keeping this going. I'm Michael Ostacher from Stanford University. Please join us on our website and follow us on Twitter at EB Mental Health. Thanks again, and look forward to seeing you all soon.